go over to the next question. Let me share screen again. So next question by Rasmoni is that injectable apomorphine, on-demand medication. So sub-Q apomorphine, subcutaneous. In a webinar, I read it said that to start at 0.06 ml starting dose instead of 0.2 ml to avoid nausea. Is there any disadvantage of using trimethopenzamide? So trimethopenzamide is an anti-nausea medication that is supposed to be safer in dopamine treatments of medication. So technically, with dopaminergic medication, Zofran or ondansetron should not be used. I don't know the exact details or mechanism why they don't work together well, but I know for sure that for dopaminergic medication, especially apomorphine, the Zofran is contraindicated. So the go-to drug have been trimethopenzamide as an anti-nausea medication, which is not a Zofran base. And you, of course, don't want to use metoclopramide because that's a dopamine blocker. So that's not a good option either in a Parkinson patient. So trimethopenzamide is supposed to be the safer option. However, the problem may have been that it's not available in the market. There were very few factories that were making the generic supply, and because there was not that much demand, and then pandemic happened, the whole supply line got shut down and has not been available. And there has been a problem even with the sublingual apomorphine. When the trial was done with sublingual apomorphine, all the patients were pre-medicated with trimethopenzamide to block their nausea before starting with the titration of sublingual apomorphine for 2 days. And then they continued afterwards for the initial couple of weeks. So when the sublingual apomorphine came out, that was the standard FDA approved algorithm on how to do titration to pre-medicate with this nausea medication. But the drug was not available after a few months or after a couple of months. And then so a lot of physicians actually stopped using apomorphine sublingual, and then eventually they were forced to use it. And then there was a small study done by the company to show that sublingual apomorphine, even without nausea medication, has the same risk of nausea. So that's interesting that they, in the study, even with the pre-medication with this nausea medication, the risk of nausea, first dose nausea with titration with sublingual, not subcutaneous, sublingual apomorphine, which is Kinmobi, K-Y-N-M-O-B-I, Kinmobi, was 30 to 40%, I think closer to 30%. So 1 in 3 patients complained of a nausea after taking the medication, and that's after pre-medication. But they recently published a small study which showed that the nausea is about the same, even without anti-nausea medication. So pre-medication does not blocks it. And then they also showed that the eventual tolerance of patient to get over the nausea and keep taking the sublingual apomorphine was about the same as the study. So basically they showed that you actually don't need a nausea medication. And they did that trial because the physicians were not prescribing the drug because of not having the nausea medication available in the market, and Zofran was contraindicated. So the company couldn't say that, okay, you can use Zofran. So coming back to the subcutaneous apomorphine, the injectable apomorphine is called Apokin, A-P-O-K-Y-N. Apokin has been available much longer, is used very commonly in UK, where actually this trimethopenzamide is more commonly available. It's still available from Canada, I believe, and some patients have gotten it that way. It's somehow not available in US. So that's one thing on the anti-nausea. There's no disadvantage of using it, but you may not need it. There may not be further reduction of nausea. You may want to use it only if the nausea happens. As for the dosing starting question, I don't have any personal experience with Apokin. I had one patient on Apokin that already was on it from another provider. I have never personally started Apokin on any patient just because I haven't felt the need, especially now that we have Inbrija, which is the inhaled levodopa, and we have Parcopa, which is sublingual levodopa. We have now the sublingual apomorphine, Kinmobi, and so on and so forth. DBS was there, Dopa was there for off times. So I've not felt a huge need or demand for starting subcutaneous apomorphine. I don't have any personal experiences. However, what I will tell you in my other experiences is that I often do slower titrations on medications in contrast to their FDA approved recommendations. That is true for Northera, which is droxidopa. That is true for Gocovri. I often don't go up to 274 milligrams, the full dose. That is true for example, Deutrabenazine, valbenazine, that is used for chorea. That is also true, for example, for Kenmobi, sublingual. So many these drugs that come out and they say, oh, this is the titration schedule. Oh, Rytary, by the way, switching from levodopa to Rytary, switching Duopa. So all these studies, when they come out, they give you a recommendation. Okay, you can start at this dose, and this is how fast you can titrate. And I often don't follow it for two reasons. The one reason is that my patients are usually much older than general study population. I have a predominantly older population in Nebraska, and more conservative. They don't like side effects and things like that, and they don't want to have too many benefits either. And the other thing to remember is that the studies are designed to show benefit. Studies' success or failure does not depend on side effect. They have already done phase 1 and phase 2 to answer those questions. What are the side effects, how safe they are, and things like that. So what they need to show in a phase 3 trial is that the drug works, and it works so good that there is no chance of statistical failure, that there is a remarkable benefit compared to placebo, good enough that they can clearly and easily pass. And they are against time. They are against time in terms of patient recruitment, patient initiation. They are against time in terms of duration. They can only, they only have 2 months or 3 months of follow-up to get benefit. So they cannot do slow titration. That will lead to poor study design or failure. They will be very expensive or very long study, very hard recruitment, or they will be harder to show benefit. So the studies are aggressive. Studies are intentionally aggressive because of economical reasons, because of design reasons, because of investigators, because of typically younger population. Typically the patients who go for research studies, research drugs, are looking for more benefit, and they are more needy kind of a patients, and they want more results. And for that reason, the culture in research is to have aggressive stance, fast, quick titration, high doses, and so on and so forth. And they also don't have the flexibility, because of the study design, to use multiple doses or say, oh yeah, if your patient's doing fine, you can stay at a half a dose. No, because all of these are confounding factors, and if the study fails, then they wouldn't be sure what caused the failure. So they have to give a clear target to everyone, and there is no patient to patient variability. Every patient goes through exact same rigorous plan. But the real life practice is not like that. Your patients are not the same. Some behave differently, some have different demands, some have different hopes, goals. In general, patients are not looking for only benefit, they're also looking for safety. They don't want to have side effects. And then most of the patients, when you talk to them, and they will say, oh, how safe it is, what side effect I'm going to have. And, the patients, as soon as patient has side effect, they will stop the drug, will not give it a chance. The patient is not being closely monitored. So in study, the patient is being seen every 2 weeks, and is getting a phone call every week. So, if they're having side effects, you can walk them through it and they will be fine. But in a real life, if a patient, if you saw him today and if you're not going to see them for 3 months, they come back 3 months later, you say, oh, what happened? He says, oh, I started the drug. I didn't feel good. After 5 days, I stopped the drug. And you say, why didn't you call me? He says, oh, I was doing okay. I wasn't sure. And I thought I'll just talk to you next time. So it's very different real life practical experience. Although there's a movement, there's a push to design studies as if they are real life, with these kind of flexibilities that I'm mentioning, flexible dosing, flexible start time, flexible titration, and so on and so forth, which is not currently the case. So that's why most of the drugs, as they come out, I am very conservative. I start with very low doses, slow titration. I do not follow the recommended guidelines. And then I get my own sense of how this drug works in my patient population, how fast can I go up? And it may take me, a year or 2 years to get more comfortable with the drug. So for example, when Duopa initially came out for the first 8-10 patients, I was very cautious in calculating, and I was doing calculations differently than the standard calculation of the trial. And my calculated dose was lower than what the calculated dose would have been using the standard formula. And plus, I was further cutting it down by 20%, 35% on start of the patient, and then titrating upward. And then after 8 or 10 patients, as I got more comfortable, had some discussion, feedback from the patients, I realized, okay, no, I can go more aggressive. And now I'm much more aggressive with Duopa. I use the standard conversion formula based on the label, and I go straight to it. and then I just have patient come in and then adjust it as necessary based on that, and that has been working okay for me. But it's not always the case. So for example, something like Northera, droxidopa, which will be other extreme example, I'm still very conservative. So typically the study was done where they started on 100 milligrams 3 times a day of droxidopa, and they went up by 100 milligrams every day. So next day 200, next day 300, next day 400, next day 500, next day 600 milligrams 3 times a day. And I still don't follow it. I typically start 100 milligrams 3 times a day. I stay on that dose anywhere from 3 to 5 to 7 days based on patient. And then I go up to 200 milligrams 3 times a day. Then I may stop there. I may again wait for a week and then go up to 300 milligrams 3 times a day. I usually never go above 300 milligrams 3 times a day at a starting dose of Northera, which is way slower and lower than the recommended titration based on the trial. And I've told a few times Northera team that this is how I do it. And I give them my feedback. But of course, they're bound by FDA label, and they have to say whatever FDA label says.